This is a little bit of some statistic of what has happened. It's not completely updated. I think it's a couple of months old, but that's good enough. With some statistic of the implants, 30 trials, 80 commercial. The range of the patient between 27 and 77 years old, so very young patient, but also older generation, older patients. Surgery time is a medium 3 hours. At the moment, you can do the operation probably in 1 hour and 15 minutes. If you do a lot of them, you get more handy, of course. All the implants were for retinitis pigmentosa. This is actually not right. There is one patient that had choroideremia. Most of these patients had just a bare light perception. You can see here some of the complications they encounter, especially in the first trial patients, the first 30 patients. There was quite high incidence of, for example, endophthalmitis and hypotony. This is due to the fact that the suture of the sclerotomy was not done properly. You have to really make sure that the eye, I'm talking about the surgeons here interested in doing this, should make sure that the eye is closed properly and that there is no leakage whatsoever. That's really extremely important. Iatrogenic breaks, about 10%, wound distance 10%. There are some people, of course, dislodge tacks because this is at the beginning a bit difficult maneuver. Then once you learn to do it after the first 2-3 cases, it becomes much easier. And in fact, if you see the 50 patients operated later, you will see with all these, we learn from our mistakes, and all the complication rate, it decreases quite drastically. There's never been anybody anymore with endophthalmitis. The hypotony is about almost normal range for a small gauge surgery. Intergenic breaks have been reduced. This, funny enough, stayed the same. Probably it's kind of a difficult maneuver to achieve. What I want to show you here is a simulation of what a patient with normal patient sees and what the difference is with a patient with Argus 2. You will see it immediately. This is just an actor which is simulating a blind patient. You will see, for example, a normal people would look at a statue normally, visual field. Somebody with RP would have a small visual field, but still be able to recognize the proper image, the proper shape of the image. While if you see now what the patient with Argus 2 can perceive is this one. There are basically different gradient of shades, different contrast sensitivity areas, and those have to be basically patient have to learn how to interpret this different gradient of light. And I can tell you they can do it very well. There are some patients which after the training perform fantastically. And of course, not all of them are like this, but I think that has to do a lot with the expectation the patient has. If the patient is well screened and he has a right expectation, usually they will perform very well. That is what in practice a patient can do with a device. It helps a lot to detect objects, which otherwise would be impossible for this blind patient to do. So they can recognize where the objects are located, they can grab objects and they can recognize them. It helps them in understanding where an object comes from. For example, if you are walking with your stick and you are trying to cross a road, they can understand where a car is coming to the right or the left side, and they can also help in the movement. Most of my patients, they don't go around anymore with a dog, but they use only the stick to deambulate on the street, for example. And some of the patients also had an improvement in visual acuity and they were able to read. There was a study we did to try to understand what were the benefits, where the benefits were prevalent in this type of patients. And we did this trying to give a patient a questionnaire and asking them what was possible to do with the device on and with the device off, or what was impossible to do, vice versa. And as you could see here, if you look on the left side, there is some simple tasks which the patient were asked to perform. And the first column here tells you what it was the percentage possible with the system on and what was the percentage possible with the system off. So for example, to locate objects at various distance, it was possible with the system on in 75% of the patient, while it was possible with the system off only in 20% of the patient. It's a huge difference. Or for example, locate and place objects in a dining table in more than 80% of the patient, only 4% without the system. So this is very statistically significant, of course. Sorting laundry dark from light, 77 against 5.9. Where the device didn't make any difference, and that is also the experience we have from our patients. Usually these type of patients, they are very used to move in their own environment. So for example, traveling within their home, there was no difference with the device on or the device off. They were already so used to do it that they didn't have any added value using the device. But for example, estimate the size of an obstacle. This is of course very important when the patient walks, or for example, detecting low-hanging branches on plants. This was also possible in more than 50% of the cases, only 6% of the people without, or also detecting the curves. These are all tasks that a blind patient, when he's walking, finds extremely important because he gets independent from the dog. These results, of course, can be measured, and these are the way we measure them, and not with the normal system or with the normal letters, but with these devices, special screens. And these are, for example, just to show you how the performance changes before the operation, after the operation. This is basically the patient were asked to localize in a screen a very little small dot, and before the operation, basically the distance between the dot and the real position of the finger was very much, like 15 centimeters. After the operation, they could almost precisely localize where the dot was located. And the same is for the motion. There is a huge difference between pre and post surgery. This is also quite striking, and this is also a phenomenon which has been also reported in animals, where basically we saw that due to the repeated stimulation of the ganglion cells from electricity, that some areas in the retina of those people started to reactivate. Because if you check the visual field of those people before surgery and after, you see that those areas are becoming, of the visual field of the patient, are becoming much larger, and there are also some new areas appeared in the test. Look, for example, this patient had only this area here. It became huge after reactivating it with electricity, and also some other paracentral areas appeared. This is just to tell you how rehabilitation is important. There are several sessions, usually 3 months after the operation. The patients are weekly appointments with the rehabilitation specialist, the low vision specialist, which trains them how to use the device. Because it's not the same, watching with a camera is not the same as watching with your own eyes. You have to learn how to move your head, to do scans, to be able to appreciate the difference in pattern of colors. And only doing this type of microscan allows patient to have a perception of the artificial vision. In this case, for example, our patient is being asked to follow in this magnetic board to try to follow the line and try to find the end of this line. And what you see here in the computer is that basically connected to the computer of the patient, and we can see in real time what the camera sees and what is projected into the electrode array. This is the electrode array, this is the image in the camera. Using this system, we can basically guide the patient and teach them how to gain again the coordination between the camera and the fingers and the hands. And this is really important to grab objects. You have to get this system back. You can see it can basically touch perfectly the end of the line. As I said, the same type of exercise, no, there is no video here, the same type of exercise to localize objects. Do video here. Oh, there was a video there. On the image, yes. And you can see this is one of the patients that is basically learning to walk only with the stick. And what is really amazing is that they can really differentiate consistency in materials. It can tell you on the right side there is grass, and on the other side is just concrete, or there is grass and then there is water, because the reflection of the image, it is difference between grass, concrete, for example, and water. And for young patients, it's really important to be able to do things independently. Even usually what we tell these patients is that they are used to go around with guide dogs, and the dog's senses that the patient starts seeing again. So what we usually suggest is that when they use the device, they should not use the dog. because once the dog senses that the patient starts seeing, it does not behave in the same way. So in which sense? It may be possible that the dog thinks the patient is seeing, and it tells him to just cross the street while a car is passing. So it gets confused. So also the dog trainers tell our patient to avoid to go out with the dogs together and with the device on, because they get confused and because they perceive that the patient sees. So what are the results depending on quality of life? We really see that those patients start being much more self-confident, that they can do things on their own. Their social life improves a lot. They go out much more, and they can sit in a bar and be able to eat and drink independently. Improve their during the ambulation, as I said. They can understand when the lights, when it's dark and when it's not dark, so that improves also their circadian rhythm. They, for example, localize bus stops, doors of the lift. They can perceive that there are people around, and they can address them directly without talking directly to them and not to the wall, for example. These are another example of a patient which could read. Is a French patient. It's not my patient, but is basically reading this small white number on a black background. And as you see, he's moving the head very little to be able to perceive that.
Oui, 5.
Yeah, 5 is 5, yeah. We have to move the head so the camera can appreciate the difference in colors. This is another patient which is reading large letters in a computer board.
Yes.
So basically they train them now to follow the lines so that they can recognize as an S. So it's a new process. They have to relearn how to see. And these are exercises that help a lot.
Is it smaller?
Yes.
Ah. Is it now?
Yes.
Okay.
Yes.
Okay, for the sake of time I go further, otherwise okay, we can take another one because this is the same reading. It's a patient who is reading, so you have to go very close and scan with the head so that they can appreciate the difference. What? You can imagine this patient was blind, so they couldn't see anything, and now they can read. Some of them, not all of them, of course. I don't want to give false hope.
What you are.
Okay. But this is, I think, what is the most important, the real life outside. They can really move independently. They don't need somebody to help them.
Maintenant, combien de photos vous pouvez voir l'un après l'autre?
They made a lot of videos. They can recognize where the little holes are, so they can avoid the obstacles and deambulate the zone.
Okay, sounds clear.
There's also a little test to see if the patient will be able to cross the street without falling, of course. And here you see that there is a difference in gradient of color between here and there, so the patient should be able not to bump into it, but to basically lift the foot and trying to not to do it. Of course, younger patients mostly they are easier and faster in learning. Yes. Next. Future developments, what we saw is that basically stimulating with a special frequency the different type of electrodes, we were able to reproduce colors. And before we thought that was not possible. It was only possible for this patient to see black and white. black and white gradient of colors, but it's also possible to achieve 7 different color combinations, as you can see here. And I have also an example in a video of one patient doing that.
That was a real buzz or boost, because I love doing
what basically you will see is that there is a screen which basically changes color, and sometimes just to see if the patient sees the changing a color, we use the same one as a, as a proof that he really saw it.
Wow, I said, that was blue, you know, and that actually brought a little tear to my eye, because I haven't seen blue for so long, and it was such a beautiful blue, you know. Some of the colours, like the yellow and the orange,
she's reporting her experience.
you know, where they sort of, they're messing about with it, aren't they? The colours are not so...
Well, not so vibrant.
No.
They tend to blend into each other a bit.
Yeah, they do, but the blue and the green, I always go on about, and I say to Joe, oh, give me a...
Yeah, this is it. So, stop. Okay, that was it. Another future development in the facial tracking, basically like the normal modern photo cameras, so that the camera itself will tell you where the face of the people around you are, so you can basically address them directly. It is also being built in the hardware and the new cameras, so the patient can see where the person is. Another development is the so-called AccuBoost, which is a zoom function, which can build in the camera itself. So this is really nice, this device, because the hardware can be improved very, very, very fast. And with the new AccuBoost 100, the image gets boosted 100 times. We have patients which could read up to 2200, which is the highest vision ever reached with such a device. This is the last video of my patients, which I think is really a superstar. He managed to achieve a lot of stuff in his life, and you will see what he's able to do now, with lots of training.
It was emotional. I was laughing because I was very, very, very happy with the light and with the skiing, and that's the most important thing. And I felt a little bit crying because I achieved my goals with the system. So that makes me a happy man. Yeah. I am Jeroen Perk. I'm coming from the Netherlands, from Amsterdam. I got the diagnosis on my 11th. I got retinitis pigmentosa, and at 18, 19, I lost 80–90% of my visual field.
You can see he's able to ski watching the master in front of him.
Today I'm here because I was skiing, and I do it with the Arcus 2 system. That's the glasses with the camera on it and a chip in my eye. The Arcus 2 system, I think it's a new chapter in my life. I got some visual fields back, and nowadays we did the archery shootings, and we did the skiing, and I think a big dream is coming out. It was in 2013. I get an email from a colleague of me, and they said they're going to introduce the system in the Netherlands. And I call with the hospital, and I get the system, and when it goes on, the system, the family was with me, and the doctor was with me, and it was very good to have the first signs of light. Nice. Now see your contours.
You see my contours?
I see your contours. I was falling with the skis, and it was very nice. I fall into the snow, and it felt good.
Let's turn around the other side.
I don't felt as a loser. It felt as a winner. Today I felt as a winner. So when I was in the cabin from downstairs to upstairs, I thought with myself, oh, I made this. This is mine. I'm a winner. Yeah. Yeah. Yeah, I was in the past. I was a skier, and I did it when I got a lot of vision. And in 2003, I did it for the last time, and I got not so many vision. And now I want to see if I can do it with the system and look after what I can see or not. That was the dream. It was very nice. I was very emotional. I want to get a little bit tears, and and it goes very very well. And there were a few times when on the slopes I can see the guide, and it was very very nice to do. So it's experience, a dream come out. I hope that the Argus 2 system goes further and further, so we're gonna have a little bit light more. And I want to thank all the people of Second Sight, but also in the Netherlands to having the system and to make this happen. That's for sure. That's most. And I also want to thank to Bartimeus. That's a rehabilitation organization, and they helped me to train with the system.
But anyways, thank you. I've been a bit longer, probably, right?
And I think you have to give him a standing ovation. Thank you, Marco. Thank you. You can sit down, and we have one more ceremony to do, but in the meantime, we'll have a floating mic, and any questions you can ask him. In the meantime, Sushmita, you can announce the next one. No questions? No, you have any questions? There's a floating mic, Dr. Purva. Yeah, she has a question. How many
electrodes are there in this?
How many electrodes are there in the Argus 2?
Okay. Yeah, at the moment there are 60 electrodes.
Can I say like each electrode is equivalent to one cell of your eyes?
What is it?
Each electrode is one
it's
cell
like
of
a one cell of your eyes?
Yeah.
I'm sorry.
No, let's say that, it works a bit different. Of course, you cannot stimulate one by one the ganglion cells, because you would need millions of electrodes, and that it would be, of course, impossible. Basically, what the electrode does is 200 micron, and it gives, basically, it stimulates an area, and the whole area gets stimulated. But what we see, if you compare the 60 electrodes performance to the German implants, which he has the correspective of 400 electrodes, because they are diodes, they work a bit different. So to get the same energy of one electrode, you need about 4 diodes, so it's about 400. The performance are practically the same, and I think the reason why is that because there is some intrinsic damage to the retinal structure anyways, so you cannot really achieve a better resolution even if you have a number of the electrodes.
Okay, thank you, sir.
Yeah.
Hello, doctor.
Yeah.
Hello, doctor.
Yeah.
I'm here.
Where are you? Sorry. Yeah.
My husband is 46 years old, and he's suffering from retinitis pigmentosa. He's lost his peripheral vision fully. He cannot shake hands, cannot grab objects, if you give him something, he cannot see, but he can still read and write completely. So when is the surgery recommended for him?
So, if he can still read, you say?
You can read?
He can read.
Yeah,
he can read and write. He's still doing his work.
Yeah, I think if he's still reading and he's still doing his work, he's not a suitable candidate for the device. The device is for people which have really bare light perception or no light perception. So when your husband, unfortunately, will, if and when he will lose also that ability to be able to read, then will be the right moment to do the implant.
Okay. And
unless it is in both eyes the same, or one eye is worse than the other one.
One eye is worse.
Okay.
The left eye is worse.
Yeah, I mean, this is very interesting, but I'm saying it here, but of course, it is still matter of research. What we are trying to do is trying to see in young patients with still residual. So, for example, like your husband, to see if they can integrate the information from both eyes. For example, we have some patients which they have some large areas of visual field, maybe not central, but they can still use it. And one other eye which is completely blind. What we want to try to do is that try to see to implant in the blind eye the device and try to see if they can work together. I think they do because the experiments that are done in Manchester with AMD are a bit similar. So they can really, patients integrate information from their own retina and from the device. It would be interesting to see, but I think still it is a matter of, this is really pure research field yet.
And I think we should wait for a couple of years before he loses more vision.
Yeah, of course.
And there might be further developments also.
Yeah.
And doctor, one more thing, like since it is difficult for him to shake hands and socially and his business work, it's an embarrassment for him. And
has it been seen by a low vision specialist? Yeah, do you have a low vision specialist?
Yeah.
Maybe it's good to have him, let him train do some session with the low vision specialist so that they can help him how to use the little residual vision he has at the moment. I think if he can learn to use that, that would be the best. And if that is not possible anymore and it cannot function anymore, then the device can be an option. Also because your husband is still young. How old was
46 years of
46,
age.
yeah, it's very young, yeah. So it would be
And,
an ideal candidate if...
can one eye be operated as of now, since one eye is weak than the other?
Can one eye be operated? That's what he said.
Yeah, that's what I was telling. That's what I was telling.
Research.
That's what I was telling. It would be on a research based, yes. Doing the eye which is worse and see if it works together with the other one. Yes, it is possible.
Okay, thank you. Thank you so much, Doctor.
Yeah.
One of your patients, my mom, who has been visiting you I think last 30 years back, she has completely deteriorated her vision and she is totally blind in terms of, she can't differentiate light and no light. So in such a case, what do you recommend for such a patient? Because I'm going to talk about two cases. One is my mom.
Yeah.
So what is the diagnosis?
What?
Diagnosis. Why she is blind?
What is the problem? Retinitis
Okay.
pigmentosa. Okay. So the point is, what are the ways in which, she is now 75 years old.
75, yeah.
75. So are there any options in which, you could have something done for her eyes?
Yes, look, age is not a problem. As you can see, there are also people around 80s which are implanted. The most important things are two. And that's why at the beginning we didn't do it, but now we introduce it in the last generation of patients. We let them always, the patient, be seen by a psychologist, which talks extensively to them and to try to understand what are the expectations of the patients. Managing the expectation is the primary factor which enables a good result. If your mother would be somebody with realistic expectation and would be somebody who would like to work after the implantation to be able to use the device, it would be a good candidate, no matter what age he is. But if it is somebody with very high expectation to be able to see, I don't know, to watch TV or to drive a car, those things, they cannot happen, of course, or would not really cope with the technology, with the device, because you have to really work with it and learn, then would make her not a good candidate. So it is per patient a different story. Anatomically, I'm sure would be probably a good candidate because she sees very little. Of course, she had to be checked by a doctor to see if it's just RP the problem, if there are other concomitant disease, other disease present. And there are some other things to be checked, but maybe it's too technical to say. But if all those parameters are good and psychologically also, it would be possible in spite of 75. It's no problem. Yeah.
Hello. I got one more question.
Yeah.
I got my colleague of mine. He also has a similar problem where the process of eye is getting degraded, macular degradation. So for him, what is it you would propose?
Is it wet or dry? Is it wet macular degeneration or dry macular degeneration? Dry macular degeneration. Also there, I mean, we are starting, this is a very new technology. We are starting to have experiments also with, as I said, in Manchester, in UK, they are implanted the first in the world with RP, with, macular degeneration. Also there, of course, when you start with some new technology, you always do the worst of the worst. There was a patient with a large scar, couldn't see anything, and that was implanted, and he had improvement. As I said, they can use the part of the periphery of the eye that still works, they can use it together with a chip. So the brain is still, so also in old patients, like for macular degeneration patient, the brain is so plastic that it can integrate the two informations. So I think there will be room for him in the future also. Now it's a bit too premature to say that I can implant an Argus 2 in AMD because it's still in research phase. It would not even be reimbursed. It would be just for him an experiment, let's say. But I think in the future it will be. Thanks. Is it first? Okay. I think I don't need anything.
Device can be used when there is retina detachment and also vision due to macular degeneration?
No, for retinal detachment it cannot be used. It's a different pathology. For those type of patients, I said there would be theoretically the possibility of having a chip in the cortex. For example, second sight is now studying a device to be implanted in the cortex with 256 electrodes. But people that can be treated with this device are people where you see a degeneration of the photoreceptors, where the rest of the retina works. The whole network in the retina works, and the photoreceptors are damaged. Retinal detachment is another pathology. It's not a loss of photoreceptors. I mean, it's completely different. And usually are treated very good with surgery. And when the surgery doesn't work and the retina stays detached, for example, there is nothing you can do with a device like this. It's not for retinal detachment.
Hello, doctor. Doctor, in case it's my son, he's a patient for ROP, retinopathy of prematurity. Of course, this thing does not cover, but are there any chances of any other diseases being covered by Argus 2?
There is a chance for all the diseases, as I said, with degeneration of photoreceptor. Actually, Argus stimulates the retina when the photoreceptors cannot do. So all the diseases that have that problem can be treated with Argus, in theory. The problem with the ROP is that your son, unfortunately, never had an experience of vision. So that, I think, makes it very challenging, if I think not possible to let him see again. Because is he completely blind from ROP?
Yeah, 95%.
Yeah, I don't think there is any possibility so far as I know at the moment. But the future.
And you spoke about the cortex and attachments on the cortex, but that thing does not apply as well.
Also for the cortex, the problem is that when you never see something, you have no really idea of how an object is made, for example, of how human being is made. So those things, of course, you have to learn to be able to have seen them once. Said that, I think probably in a child is possible, maybe with other device to maybe try to teach them, but I don't think the cortex will be able to function anymore. Probably you should think of another system, maybe tactile, but I don't think cortex would work. No.
So just an extension of this question. So if there is a retinal detachment due to ROP, and the child has not been able to see any time in one's life, so do you have any visibility on, in the near future, is there a scope for any other treatment that will?
The problem is that, as I said, as far as my knowledge, and I don't know if not you have other information, but once the cortex is not being developed because you never had the visual stimulation, there is nothing you can do to reverse the problem. So if the problem is bilateral and it is since birth, there is no way, as far as I know, and I think you agree, to be able to establish vision in these patients, at least with the knowledge of now.
Yeah, I just want to ask one thing basically.
That is a bit different because there's been stimulation, so he sees 660s, so it's not blind. So there may be some possibilities. Yeah.
See, I'm.
Yeah. Look, I think whatever, if you ask me if there is something you can do now, I tell you no. But if somebody who had experience of vision, I think with technology in the future, we may be able to try to improve it. After, sorry? Yeah. Yes, but I would say that it's not for him anyways, because the 660 vision that he has, it will always be better than the artificial vision a device would give anyways. And he's very young, so from now, look how many steps we did now in the last 15 years in this field. I think from the time that he's going to be old, there's going to be so much new thing coming out that I would keep the hope open.
I'll just take 1 minute. I'm a patient of Dr. Natarajan. I was diagnosed of mild CSR with a small PED in right eye. So if I close my left eye, I don't see properly. Even I can't read that Endowment award properly. So is there a possibility of restoring and getting a normal eyesight?
Normal is a problem, but I think if there's a PED and if there's something active seen in the angiogram, there's a treatment of low fluence PDT, photodynamic therapy is possible. But for that you have to find out whether any active lesion is there which can be treated. If it is an old lesion, right now we don't have treatment.
It's an old issue basically. Last I met you in 2006 and I was advised that to just go slow and watch.
Yeah,
so since then I could not come to you.
I know. So I think since the other eye is good, I think you have to protect it and give a routine checkup. That's it.
So probably I will take an appointment and come to you again.
Sure.
So I have a question for Dr. Mura. I'm discussing cases of my students as Dr. Radhika introduced voice vision trains blind people with computers, rehabilitated them to go back and lead their dignified life. So coming back to my question is, there's one girl who's a premature girl, but only her optic nerve is not working. Her eyeball is perfect, everything is perfect, and she can't see. She has never seen since childhood. So can she be operated by this and get this device?
No, unfortunately, no. It's the same problem. When you never had a visual experience, you cannot really have a device that can help you to have that, because it's really a cortical problem. The cortex has never worked and it's never functioned, so it will never happen. No.
And someone whose eyes has shrunk, who could see earlier, but the eyes have shrunk, so that could be operated?
Shrunk means?
Phthisical.
Well, also there is not possible, because once the bulbus is phthisic, that means that there is really no function in the optic nerve, which is in the retina, which you need to have a viable retina to be able to send the light to the signal to the brain.
Thank you.
Dr. Mura, I have RP and I'm blind for the last 20 years. In case I have this Argus 2 implant done now, in the near future, if a real treatment comes, say the stem cell, can this be removed and that therapy done?
Yes. Look, this is a question a lot of people ask me, because they say, look, if I don't have the surgery now, maybe in 10 years, it's a better device of something new. The device has been removed, has been explanted already in several patients. So it is possible to remove it, and with no damage for the patient. Another thing you may consider is that what I said before, while you have electrical stimulation of the retina, is not only the fact that you can perceive the patterns of light, but many of the patients, they got also like an amplification of the ganglion cells that they were not working before. So it looks like electrical stimulation itself it is something which is really good for the eye, and it keeps the retina trophic longer. So in that case, I would say there is no really anything against doing an Argus now, even though in 15 years or 10 years there will be something better for it. And you have always the other eye which is available for treatment.
And the same goes with the cortical implant also.
Sorry?
The cortical implant, even that can work later on when it comes.
I think so. The cortex are so they can be located in two separate places. So if you do the right eye, the left cortex, or the left eye, the right cortex, yeah, it's no problem.
Thank you.
Do the trauma is blind in one eye? It's completely blind, no vision. No. I would say also for him, at the moment, is not the good solution for sure. The other eye is absolutely perfect, as you said. Even, let's put theoretically the case we would implant a device in the bad eye. And let's put the case that there are some cells which are still working and they would probably send the signal. It would always use the good eye. It will never use the other eye. So I think it's really no option anyways. I mean, I don't think it's no. The answer is no. Yeah.
Yeah.
I don't know.
Okay.
My son is 36 years old, and for last 5 years he cannot see with both eyes. But from the birth he was short-sighted. High myopia was the first disease, and then he got this cataract and glaucoma. Our doctor tried the best, but he cannot save his eye. Can this artificial retina, also last was the retina detachment. Now what can you help us?
No, it is, what you say is another, as I said, the device is just meant to treat people with the degeneration of photoreceptors. What your son had is several pathologies, unfortunately, which make the operation with the device impossible. He has glaucoma, he has detachment, it's impossible. Yes, for sure, for sure. How old, sorry?
31 years old.
My daughter. She was diagnosed for RP at the age of in 95 by Dr. Natarajan only. Up till now, she has got about 25-30% vision in the eye, both the eyes. Evenings are bad for her. But daytime, she has, after that she got graduated also. She's a professional influence agent also. Any chances of for this surgery, whether this there?
I think for her at the moment is not a good indication anyways, because she sees still 25-30% is not bad. I mean, and as I said, the vision, the normal vision we have, even if it's 25-30, will be always better than an artificial vision. Remember, artificial vision, it is something, artificial, which is generated by a computer and which is basically sent through a little electrode, which are limited resolution, so will never be as good as what your daughter has now. It is meant for people which are blind to get them back of the blindness, to get them back to the light.
Thank you, sir.
Sir? You can ask him.
I'm a pregnant and I'm with independent pigmentosa and it's very shaky. So what do you do?
Nystagmus.
Nystagmus. RP. You. But what is your vision now?
How much is the vision? Yeah, 636.
Yeah, it's too good. Yeah. I mean, it's too good. It's too good to have the implant. The shaky vision, what you said, nystagmus is not a problem for the implant. The problem is that it's good that your vision is so good, so you don't need an implant. But for the shaky eyes, most of the patients with RP, actually, basically almost everybody has nystagmus. Yeah. Okay, no, there is absolutely no problem with that. The only problem is that basically, as I said, in the implant there is a little antenna, and in the glasses there is a little antenna. If somebody has a very large nystagmus, the antenna sometimes can go far away from the antenna in the glasses, and you can lose connection. But that can be trained, and usually what we see is that the patient, after being trained, the nystagmus almost stops or become very little. So there is no lack in the image, absolutely. What you can happen is that at the beginning you may lose the signal, but that it gets improved with training.
Hitesh.
Sir?
Yeah, you can ask.
Sir? Hello?
Yes, yes. You can ask, sir.
I am suffering from retina RP patient. I have degeneration of retina patient and I have only 4 degrees center vision. Is there any helpful for that? Any remedy there for that? Center vision is only 4 degree.
4 degrees.
4
Yeah.
4 degrees. And a visual acuity?
What is your, how much lines you can read in the board? How many lines you can read in the board?
And I have not seen anything.
I've not seen anything.
Only center vision
So
is
you have
4
just...
degree.
Oh, central vision, can you read anything?
Yeah, before 6 months I can read mobile numbers.
Today?
From where light will come, it will I am seen.
No, today?
Today I am not able to see. I already 2 months back I had the cataract operation.
Okay, no, but how much you are able to see?
Now I am not seeing anything a long distance. Short distance I can see, and what light will come from back side, then I can see.
Please have
Okay, yes, probably. Probably you have an island which is not paracentral, and you're using that one to see.
Yeah.
In theory, you could be a good candidate, yes.
I can see TV, but I can from where back side light will come, then I can see. I can see signboard. I can see TV. I can see.
If you see TV, probably you have more than what you think. I think you should check it. I think the best would be to check first what your vision is, to have a real number, and then low vision aid, and then have a look. Because if you say you can see TV, to be able to see TV, you must have at least
I can see even signal, road signal is there. I can see. Then I can see a backlight of car and everything.
I think your problem is that the island you have is paracentral. So sometimes you use it and sometimes you don't. Probably you should go to low vision to help you to use the paracentral island.
Yes.
You have it also by you, eh?
Remedy is there, no?
No, there is no surgery, but only low vision aid you have to try.
Is there any remedy?
No remedy. This procedure is only for blind or partially you can see light. If you can see little more than that, if you see little more than that, this will not benefit.
Okay, thank you.
Sir, my first question is whether AMD, age-related degeneration, is hereditary. Because my mother, who is 80, has lost vision last 15 years. Sir has operated twice, PDT has been done. And now for me, last 7-8 years, I am now 58.
Yeah.
And even I have the AMD.
Yeah, but the answer is yes. It's known that there is a genetic component in MD. That is well known, yes. There is a genetic component, yes.
So no, my mother is 80. She has no vision. Can she be operated at this age?
But if the problem is AMD, it was a wet AMD, I presume, right?
Yeah, it was a wet one treated.
Yeah.
Counting finger vision for the mother.
To be honest with you, what we are doing at the moment is for dry AMD. For dry AMD. Wet AMD, if you get a large membrane with a lot of fibrosis, I don't know if that is the case, if there is a lot of fibrosis, the whole network of cells is completely destroyed. That's why you cannot do much. With dry AMD, the network of cells is still there. So the advice for you is that to be kept under good control, to try to avoid the fibrotic stage.
Doctor, hello.
Yes, sir. You can ask.
Hello. My grandson of 15 years age, studying in 11th standard, suffering from macular degeneration in both the eyes. Now, with the help of writer, that he's been appearing and writing all papers, question paper and all, but whether there is any remedy or any operation or any artificial device that he can see fully.
No, but can he see the board now? He can see the board
now. Only small print he can't see.
He has
only small prints he can't see. Question paper and can't read. Help of only writers that he is appearing in the examination and passed for the last 4-5 years, 6 years. He was examined in the Aditya Jyot only, Dr. Mihir Kothari, and he said that he will be standstill. So whether any remedy or any operations or anything?
No, not right now.
No, not right now.
This device is only for blind and partially you can see light. Not for people already see.
Okay, okay. Thank you, sir.
Yeah? Surgery done.
10 years before I have done operation in Aditya Jyot hospital, Dr. Hussain has done. He has given me guarantee of 20 years, 10 years become. But suddenly right eye, it became blind.
No, but what is the diagnosis? Diagnosis.
I can't see in this.
No. Diagnosis. What is the cause?
I don't know.
You have to check. You have to check, no?
No, for this I have done operation. This I have not.
No, but
touched
without
anything.
checking, how do we tell? You have to check the eye.
No, see.
No, you can't do like that. No, we can't check like this. No? If you can check like this, why get a professor like him? No? Yes.
In the right eye, he has he operated 4 times of retina detachment. So can we try like in left eye or right eye?
No, this procedure again is not for retinal detachment. This procedure is only for retinitis pigmentosa.
But left eye can we try?
No, it's not for retinal detachment eye.
But left eye, what he had left eye?
Left eye he lost at the age of 10.
For what? Why?
Retinal detachment.
Retinal detachment.
Yes.
Okay, no. It is just for retinitis pigmentosa and in the future for dry AMD.
Yes, correct.
Yeah, dry.
No. For a dry macular degeneration, not for detachment.
My question is to the doctor. Actually, my father is suffering from high AMD.
Yeah?
And earlier on, treatment was done by providing Avastin. Twice Avastin was provided.
For dry AMD?
No.
With Avastin?
No, wet AMD.
Ah, wet AMD, okay.
I'm not sure it is provided.
Hello.
Avastin.
Yeah.
So I consider that your treatment for AMD, the
Hello.
treatment that you are considering, it is not for wet AMD.
No, for wet AMD, the treatment with Avastin is the right treatment. I mean, this is just for people which are losing central vision due to dry AMD. And it's just a trial started now, so it's just very new. It's been done only in United Kingdom, in Manchester, and it is for people with large scars in the center due to macular degeneration. For wet macular degeneration, for leakage of blood from fluid from blood vessel, the Avastin you got your father is a good treatment, and there are also other drugs similar to Avastin you can use, depending on what the response is. But Avastin is the right treatment. Yeah.
We were saying that Avastin was a cancer-related medicine, right?
A cancer medicine, yes, it's used also for certain type of cancer.
Are there any other further medicinal treatments that are provided after Avastin?
If there are other medicines that it could be, yes, there are, of course. In India, there are Lucentis, Eylea. You have it, yeah? I think so.
Yes, Eylea is still not come.
Yeah, there are some let's say, some other molecules which are meant to be used in the eye, which are similar to Avastin. They exist. It is also in India. I checked now with Professor Natarajan.
Is there a process that the vision will be restored, or
Usually, the treatment is just to stop the deterioration. And some of the patient restore. Percentage of the patient, the vision restore, but the aim of the treatment is try to stop the deterioration of the vision. Yeah. Hello.
Yeah.
Any treatment for diabetic retina detachment?
No.
We have been operated at Central Electronics
Surgery.
6 times.
Diabetic retraction.
Yeah, the treatment for diabetic retinal detachment is surgical treatment of the detachment, but not with such a device. No. It's a surgery. That Professor Natarajan maybe can help.
Sure.
Good evening, doctor.
Good evening.
My daughter-in-law, having 40 years age, she sustained injury in the left eye by putting one spring, iron spring. There a lot of blood was out. She was operated for cornea, stitches, 18 stitches were there. My honorable sir, I also examined her at your hospital at Badala. Retina, cornea में sorry stitching was there. Retina is okay. Internal जो nerves goes to the brain, that is also absolutely okay. And that lens is missing.
Lens is missing.
So she is not able to see now.
What is the other eye? What is the other eye vision?
Sir, other eye, okay, only injury was in one eye usually.
I know. So this device is not for the person with one eye.
No, I mean to say, this retina and cornea and lens are replaceable or not?
Pardon?
Replaceable hai
Yes,
ya nahi?
the cornea and the lens, yes, they can replace.
Sir?
Not retina, not retina.
Retina, no.
Not retina.
No.
Only the cornea can be replaced. Only cornea.
Acha, retina is okay now.
Yes, but cornea can be replaced. Lens can be replaced.
And vision will come back.
No, we have to check the retina and optic nerve. You have to check the function of retina and optic nerve. Function.
I see. So it needs operation.
No, sir. You have to check diagnostic test ERG and VEP whether the optic nerve and retina are working or not.
Okay, sir.
If it is functional, then we can do operation.
Then there will be percentage of vision or as usual?
No, but first we
normal?
have to check the function, no? How much is the damage? If it is damage, that much will not come.
But vision may likely to get back.
No. This is a problem of patients. No? You want to listen, what do you want? But the fact is, you have to check the retina function. Like for heart, you do ECG, you have to do for retina ERG.
Okay.
And for optic nerve, VEP.
ECG and ERG?
Not ECG, ERG and VEP.
ERG and VEP?
Yeah.
Thank you.
Image simulation. If I can't say I can't understand that, could you describe the image simulation where the patient has to train that?
That's why, about what you said about after the implant, the vision stimulation by the rehabilitation and the psychologist. You think, how can you do that?
No, there are some tasks that they have to learn to do. They have to basically, there is a specialist in low vision which tells them what to do, because you lose basically the coordination once you are blind. You lose the coordination between your hands and your eyes. And then when the camera comes there, you have it again, but it was only one eye in the middle. So the coordination between the single eye in the middle and the hands is different than with both eyes. That has to be retrained. Yeah, the image that comes in your brain is a pattern, and it depends on what you are watching. You can recognize the edges of a face, but you cannot see details. So, for example, you can see where the face is, you can see the contour of the face, but you don't see, for example, in detail the eyes of the nose or the mouth. But you see where the face is. Yes, some patients, not everybody, because depends on several factors. How good is the retina? Not all the retinas are the same state. Some are more damaged than others. It depends how good is the guy in doing the scan movements. It depends how good he can select the filters. So not all of them can do it. Let's say probably about 15% of the patient can read, and the rest no.
So. No, I am ready to support, but you need Government of India to give approval. And the second is the implant, second site says we can do a 5 implant trial, but each implant is going to cost 2 crore, and somebody has to sponsor. So nobody is No, not the patient to spend, but somebody has to sponsor, I said, either a government agency or a funding agency, some funding agency or a private agency. So, and nobody can pay because you don't know how much he is going to see. So that's the problem now. And the first is Government of India wants any instrument for, I think 5 or 20 patients they are telling. Each patient is 2 crore. So it's stuck. The second side people have come already to our operation theatre, and even Dr. Marco, we have sent my certificates where he allowed us to bring patients to Netherlands and operate. But again, the problem is money.
Yes.
Who's going to fund it? There, either the insurance pays, like rather. Yeah. Yes. So and then our friend in Italy has a church which gives money for each implant. So I think somebody has to give.
Yeah,
correct.
It's about that.
Yes. Correct.
About that.
So for a want of time, I want to thank Marco for all the question and answers, for the beautiful presentation, and thanks for giving the standing ovation. And we also have a pleasant duty to do. We just have a donor who has given money for a project called Dr. Abdul Kalam Pearls project, which can I invite, can I announce? Where is the check? Come, can you announce? Yeah. And I also, in case you have any questions, you can write to us. Hitesh is in the invitation, the email ID is there. So whatever we can answer, we will do it. And whatever answers we don't know, we'll ask Professor Makamero. Can we ask Mr. Krishnan, sir? Sir? Mr. Krishnan, sir? Sir, you can come up. So we have a donor, that's Mr. Krishnan here. So we have made a project supported by him and his late wife, Mrs. Krishnan, and who is supported by his son and daughter, Dr. Radhika here. And he has given a generous donation of 15 lakhs to the project called the Dr. Abdul Kalam, ABJ Abdul Kalam project.
Friends, I have to thank Dr. Natarajan for giving me an opportunity to donate for a noble cause. I hope these things will build up so more people can offer for the removal of blindness and defects in vision. Thank you. I think I'll keep it short. Okay.
Yes, sir. Thank you very much.
I would like to invite Dr. Radhika to share the vote of thanks.
On behalf of Aditya Jyot Eye Hospital and the Aditya Jyot Foundation for 20 years, I would like to thank you all for being a part of this little public endowment lecture in the name of late Professor Dr. N.S. Sundaram and Mrs. Kamala Sundaram. I would like to thank Dr. Marco Mura for taking the trouble to fly halfway across the world to be with us here and give this wonderful talk. Thank you. And I'm sure it has benefited, at least given a little nuggets of knowledge to all of us in the auditorium. I would also like to thank Sushmita, who's readily agreed to host the program because she's also extremely well-read and is actively following up on all research that is happening in this area. I would like to thank CIPLA, who has made this event possible. They have been strong supporters and their educational grant has helped us in conducting this program. And I would like to thank the entire staff of Aditya Jyot Eye Hospital and the Aditya Jyot Foundation for making this event possible. I would like to specifically also thank Hitesh, who has been coordinating the entire thing. Thank you all. Thanks once again for being with us here today. Thank you.